We'll be talking about serpiginous choroiditis, a rather often, I would say, seen but not definitively diagnosed always in the clinics. So I'll be talking, spreading out my talk in terms of definition, the clinical features, the diagnosis and the differentials to be considered, and the management of serpiginous choroiditis. This is a normal flowchart of an approach to a choroiditis patient that we see. Serpiginous has been classified classically amongst the focal group of choroiditis, and the important point here is vitreous negative focal group of choroiditis wherein serpiginous has been classified. So why this classification has come up, we'll see. Serpiginous choroiditis is by definition a chronic bilateral asymmetric progressive inflammatory condition affecting choriocapillaries and the outer retina, called serpiginous because of the wavy or the indented margin that it carries. Serpi typically means to creep. Where does this come from? Because the lesions in this chronic disease, though generally are bilateral, they are asymmetric and they can lead to permanent scarring. It is very often a recurrent disease. And as I was saying, the lesion is called as serpiginous because of the ability of the lesion to creep. The newer lesions keep developing at the border of the older lesion, so that over follow-up you can make out the lesion extending from the disc, moving out further into the macular area along the arcades, further spreading around towards the edge of the macula or even to the equatorial side. So that is why the lesion called as serpiginous choroiditis. It appears like the borders, typically described as borders of a continent in a map. It has a wide spectrum of disease presentation. In India, out of all the posterior uveitis, 19% of the patients have been classified as serpiginous. In Western population, it has been reported to be about 5% of total uveitis. It is typically seen in healthy adults, male more common than females, age more closer to 30, though it is from 30 to 70 years, no familial predisposition, not associated with any systemic disease. Important here is, this is important in terms of differentiating it from its differentials. A lot of patients, about 50 to 75% patients develop visual loss, and the vision is less than 20 by 200 in about quarter of a patient. Pathologically, it typically involves atrophy of photoreceptors, RP and choriocapillaries with lymphocytic infiltration of the choroid, along with at times secondary choroidal neovascularization. Though the disease is typically described as a bilateral entity, you have very often asymmetric presentation. You will have one eye getting involved first and the second eye coming much later. Very important, the inflammation as you typically see, the anterior cells flare, the vitritis is generally absent in serpiginous choroiditis. Lesions are classically peripapillary and then they spread outwards, and the disease progression is stepwise and again asymmetric. It may have skip lesions in between. It may progress faster in one eye and slower in the other eye, eventually leading to permanent scar and fibrosis. Clinically, it's important to differentiate types of serpiginous. We are in a country where we don't have fancy investigations when we are sitting out in our clinics. PCRs and all those things to differentiate, differentials are not very important. So in a lot of uveitis sessions, you will see a lot more emphasis being laid upon clinical presentations, and it's important to differentiate there. You can have a classic peripapillary geographic kind of a serpiginous, also known as peripapillary choroiditis, helicoidal peripapillary or geographic choroiditis. These are the synonyms which are used with it. Typically, these are 80% of cases. They generally start off around the disc. As I told you, they spread along the arcades. There are multiple patches in different stages of growth, and the new lesions develop at the edge of the older lesions. You can also have skip areas in between. They remain asymptomatic till the time macula starts to get involved. Once the macula is involved, only then the vision starts to drop. You can also have a macular serpiginous choroiditis. The lesions are very much looking like serpiginous. The only difference is they don't start close to the disc, they start very much close to the macula. They leave behind similar looking scars, but they cause much worse visual prognosis. They have much higher incidence of choroidal neovascularization. Amongst macular serpiginous, what has been seen is most of the vision loss is either because of foveal atrophy, or almost 50% also can have CNVM because of macular involvement in these cases. The third type, which is also known as atypical amphigenous choroiditis. This is very much similar in appearance to what Dr. Tinku was talking about, was tuberculosis associated serpiginous choroiditis. They have multifocal patches, more often seen in the periphery and peripheral equatorial area. They are isolated patches. Again, there is no vitritis here. The lesions look again typically like serpiginous, but they are now more in peripheral, they are more multifocal, and they again have recurrent episodes. You can make out in these photographs, these are peripheral lesions. The macular area doesn't seem to be that involved. The posterior pole is involved in some eye, in this eye it is involved, is less involved in the other eye, and you have these peripheral patches which you can make out. Again, no vitritis. Diagnosis of serpiginous, though FFA is generally used as an investigative modality, FFA is not characteristic of serpiginous. FFA is like any other choroiditis. You see early hypolesions which later turn out to be hyperlesions, which is typically of any kind of a choroiditis. This hypo is because of either a loss of choriocapillary non-perfusion, or it could be because of the retinal or the RP edema overlying the area of inflammation. And the inactive lesions typically like a scar stain. Other tests like ICG can be done which show hypofluorescence much more than seen on FFA. Visual fields in active lesions show a dense scotoma. In inactive lesions, the scotomas are less dense. ERG, EOG not really affected, very rarely affected in advanced form of the disease. Coming to the differentials, the two important ones are, one is APM-PP and the other one is serpiginous like choroiditis following tuberculosis. Classically, APM-PP lesions also look very much like serpiginous. The difference here is they resolve within 2 weeks without causing much of scarring, much of fibrosis. There is generally an associated viral prodrome. There is generally a very good prognosis. Vision is much better than 20/40. Unlike serpiginous, which leaves behind a lot of scarring. They also don't have any vitritis. And once the APM-PP lesions heal, you just can make out some subretinal mottling there in those areas, but there's no real scarring which is seen. That's why the vision is very good in these cases. The other entity is presumed tuberculosis like serpiginous like choroiditis. The important differentiating point herein from a serpiginous, from a tuberculous choroiditis is, one, obviously TB endemic area like ours, it is much more common to have these kind of lesions. So we always have to have a suspicion of tuberculosis in these conditions. Vitritis is very significant in such patients. Vitritis is quite marked in patients with tuberculosis, the younger age group, and you can have again contiguous or non-contiguous areas, may involve juxtapapillary or maybe only peripheral, and again they have a very rapid progression unlike serpiginous, and leaving behind a lot of significant pigmentation. If you ask me to differentiate, I think presence of vitritis, a severe vitritis would point more towards a tubercular entity rather than a serpiginous entity, especially in India. In terms of complications, CNVM occur in about 15 to 35% of patients. They generally occur at the edge of the scar or the heel lesion. You can also have serous retinal or RP detachment, subretinal fibrosis. Rarely you can have macular edema. Neovascularization, not very often seen. Coming to the management, the goal of the therapy here is to control the active lesion rapidly and to prevent further recurrences and progression. Our main aim of treatment, main arms that we have steroids, we have immunosuppressants, we have infliximab, and then we need to treat our secondary neovascularizations also. Steroids are typically given to arrest the acute attack, shorten the duration of the inflammation. They really do not have any role in preventing recurrences. You can have recurrences on tapering. You can choose intravenous or oral depending on how rapid response do you really want. What we typically say is that the lesions are too foveal. We can start off with intravenous methylprednisolone. Otherwise, most often we start off with oral steroids. Intravitreal steroids, nothing has been reported as a role in serpiginous choroiditis. This was one article which showed intravenous pulse methylprednisolone for acute treatment, and all 5 patients did show significant improvement in vision. In terms of immunosuppressive agent, you have cyclosporin, azathioprine, cyclophosphamide. But all these immunosuppressive, we have to keep in mind, they all have significant systemic side effects. So whenever we are starting a patient on these immunosuppression, we generally do it for recurrent cases. We do it with the consultation of an immunologist who are much more versed in taking care of the side effects also. And you need to advise a patient regular battery of investigations when they are on this systemic immunosuppression. Immunosuppressives have been shown to reduce the rate of recurrences. They are typically indicated in refractory inflammation when the recurrence rates are high. You can use them if your macular involvement is too much, and as a steroid sparing drug if the patient has side effects to use of steroids. In terms of study comparing head-to-head monotherapy versus immunosuppression, recurrences was seen in all patients of those who were on steroids compared to those on immunosuppression. The recurrence rates were much lower. You can also have something called as triple agent therapy. In this, there is a synergism of azathio and cyclosporin along with side effect. You use them in lower doses to reduce the side effect, at the same time have a synergistic effect on the lesion. There's an article which showed combining prednisolone, cyclosporin, azathioprine, and the patient's infiltrate resolved in 2 weeks and tapered at 8 weeks. They were continued for about 6 months, and the recurrence rate were much less. You can have other alkylating agents such as cyclophosphamide, chlorambucil, and they are reserved generally for uncontrolled diseases. Follow-up is advised even after revision. Patient is continuously kept under observation, if at least for 6 months more. Home OMSLA monitoring is advised. We review the patient 6 weekly, then slowly keep increasing till 6 monthly. Coming to the conclusions, serpiginous is a rare progressive disease of the middle age. Must exclude TB, especially if a patient is from endemic area. Treat with standard immunosuppressive steroids to treat active lesion and prevent progression and recurrences. Always keep a potential for secondary CNVM in mind. We need to treat it separately. Thank you.